This lecture is over pediatric musculoskeletal conditions. Scoliosis is the S-shaped lateral curvature of the spine. It's one of the most common types of abnormal curvatures of the spine. It's more common in girls than in boys. We can see scoliosis occur alone, or it can be related to other conditions such as cerebral palsy or muscular dystrophy. The occurrence of scoliosis is most noted during pre-adolescent growth spurts. And so screening is done during well-child checks periodically throughout adolescence. Signs and symptoms of scoliosis may include uneven shoulders or waist, one shoulder blade that appears more prominent than the other, one hip that appears higher than the other, and oftentimes clothes not fitting correctly. If scoliosis is suspected during a well-child check, X-rays can be utilized to determine the specific angle, degree of angle curvature on the spine. One way that an angle measurement is taken is through the Cobb angle measurement, which is determined by a physician with the aid of an X-ray. Cobb angle measurements can be rechecked periodically to determine if the angle of the curvature is getting worse. Another approach to diagnosing scoliosis is determining the risk that it will get worse through what is known as the Risser sign. The Risser sign measures how much mature bone has developed along the iliac crest. This is also a test done with an X-ray, and the values range anywhere from a 0, which means there's the least amount of ossification at the iliac crest, which would indicate the greatest risk for progression of the scoliosis, to a 5, and that's going to indicate that there's been complete ossification of the iliac crest, which would indicate the lowest risk for progression of the scoliosis. Treatment of scoliosis depends on the degree of the curvature. Curvatures less than 25 degrees generally just require monitoring. Monitoring will be done both with periodic physician visits in addition to some X-rays to determine if the curvature is getting worse. In many cases, no treatment is necessary for minor curvatures of the spine. Curvatures between 25 and 45 degrees do require the use of removable braces. These braces are worn to stop the curvature from worsening. They're worn the majority of the day. Bracing is the standard treatment for the moderate curvatures, and this consists of braces known as the Milwaukee brace, the Charleston brace, and the Wilmington brace are some examples. These are customized to the child's size and shape and can be replaced also as the child grows. In the most significant curvatures of the spine, those greater than 45 degrees, it does require surgical correction to keep the scoliosis from worsening and to straighten out the back. A couple of surgical procedures that they would use are the spinal fusion and the bony fusion. With the spinal fusion, this involves internal fixation with the placement of rods into the vertebral column, and the bony fusion involves the placement of donor bone, usually from the iliac crest, to fuse the spine. The child with scoliosis surgery needs to follow some general post-op considerations. Some specifics to keep in mind regarding this type of surgery would be that most children will be hospitalized for approximately a week following the surgery. They're going to be ambulatory, usually on about day 2 or 3. In some cases, it may be up to day 5 before the surgeon allows them to be ambulatory. And there will be important patient teaching that needs to be discussed with the patient and the family regarding a timeline for the resumption of normal activities. The next pediatric condition that we're going to look at is developmental dysplasia of the hip. This is a medical term for a general instability or looseness of the hip joint. There are a couple of different types of hip dysplasia. The first, known as acetabular dysplasia. This is when the ball remains in the hip socket, but the hip socket is too shallow to appropriately keep the ball in place. Then you have subluxation. Subluxation as a type of hip dysplasia can be broken down into 2 subcategories. Oftentimes they'll refer to a subluxation type of dysplasia as either subluxable or subluxed. And the difference here is with a subluxable type of hip dysplasia. The ball is located normally in the socket, but in certain positions, such as when pushing on the hip, the ball can be partially pushed out of the socket. With a subluxed hip, the ball in the resting position, the ball rests part way out of the socket. So subluxation, the main thing to remember there, it is a form of what we call a partial dislocation. The ball has not completely been removed from the hip socket, but it is partially removed, or it's capable of being partially removed. Obviously, then the last one there is the dislocated type of hip dysplasia. And this is when it's dislocatable, if it can be dislocated easily. And obviously, then it's just dislocated if it's completely out of the socket, even when the child is at rest. So with a dislocation type of dysplasia, the ball is completely out of the hip socket. As far as diagnosis with developmental dysplasia of the hip goes, it may not be detected at birth. It's looked for, and assessments are done from birth on to observe for the presence of this type of problem. However, it's not uncommon for it to not be found until follow-up well baby visits. So pediatricians will monitor carefully for the presence of developmental dysplasia throughout the child's first year of life. A couple of routine tests that are done during these pediatric visits to check for hip dysplasia are the Barlow's test and the Ortolani's click. With the Barlow's test, the pediatrician will adduct and extend the hips in order to feel for the dislocation to occur as they move the lower extremities. With the Ortolani's click, they will be feeling and hearing the click, as with gentle pressure, the pediatrician actually presses the hip back into the socket. Some other evidence of developmental dysplasia of the hip includes noticing asymmetrical gluteal and thigh folds. If you were to take the infant and place them in the prone position and examine the folds down from the gluteal area down the thigh, you would notice an asymmetrical difference between one leg to the other. There are a couple of different options for treatment of this particular problem. It does begin immediately as soon as the hip dysplasia is diagnosed. A couple of things that they would try is, one, they can utilize what's called the Pavlik harness. This is used up to 6 months of age, and it can be used for up to 12 weeks at a time. One of the most common practices that they use when they find developmental dysplasia of the hip at a young age. The Pavlik harness is used to keep the hips in a position of abduction, and it is important to adjust the straps frequently as the infant grows. Keeping the hips in a position of abduction and flexion is one of the best ways to actually keep the femur head in the socket. If this can be done for a period of time, then usually the hip joint can grow and develop to the point that it can maintain the ball in the socket. However, in the event that an adduction contracture is present as a result of the dysplasia, it may be necessary to use what is known as Bryant's traction. This can be used on children up to 2 years of age, and this type of traction keeps the legs at a 90-degree angle. You'll notice the image in the slide is a depiction of a child in Bryant's traction. In Bryant's traction, the child is lying on their back. The traction holds the legs upright at the 90-degree angle and lifts the buttocks slightly off the bed. The weight on the traction gently stretches the child's leg. This helps to loosen the ligaments, tendons, and muscles around the hip. After a number of weeks, the child's hip will usually be repositioned under general anesthesia, and a hip spica cast will be applied following the use of Bryant's traction. The surgical correction of hip dysplasia, if that's needed, is usually not done until after 6 months of age. Surgical correction would involve a closed reduction and placement of a spica cast. Spica casts are usually going to be in place for about 3 to 6 months. And just like the Pavlik harness, a spica cast would keep the legs in a frog-like position. Just another note about Bryant's traction, this is also used for fractures of the femoral shaft in children. Clubfoot is a congenital anomaly where the foot is twisted either inward or outward. Oftentimes, this can be caused by something as simple as improper positioning in the uterus. Despite its appearance, clubfoot generally does not cause any discomfort or pain to the infant. And clubfoot could also be caused due to other types of congenital deformities. There are generally 4 different types of clubfoot. One is known as postural clubfoot, or also called positional. This is a benign type of clubfoot that is usually due to, as I first mentioned, really just intrauterine crowding or that improper positioning in the uterus. Idiopathic clubfoot is the second type. This is also referred to as congenital clubfoot. This is the most common type that we see present at birth. It is a congenital anomaly. It can be seen in 1 out of every 1,000 babies. And about half of all cases of clubfoot only involve one foot. There's no known cause for the idiopathic clubfoot, but we do know that baby boys are twice as likely to have it as compared to baby girls. And with this type, the foot tends to be very stiff or rigid, and it is hard to manipulate. The third type of clubfoot is referred to as neurogenic clubfoot, and this is when it's due to some type of underlying neurological condition, for example, cerebral palsy or spina bifida. Our last one is called syndromic clubfoot, and this is found with other types of clinical conditions such as dwarfism, tibial deformities, and what is known as constriction band syndrome. So this is when something other than a neurological problem has contributed to the occurrence of clubfoot. Syndromic clubfoot is usually more severe and difficult to treat and has the lowest degree of positive outcomes for the child. In most cases, treatment is usually very successful with clubfoot. It's going to consist of things such as stretching exercises and casting, or sometimes taping methods to slowly realign the foot back into proper placement. Sometimes surgery is needed. One of the most common things that's actually done is casting, what we call serial casting. The casts are reapplied frequently as the child grows. Oftentimes they may apply the casts as often as every week, and they will manipulate the foot slightly and recast it every week. When the other options aren't effective, surgery is one approach that they can utilize to treat clubfoot. But even with surgical treatment, it will still need to be followed by casting for up to a month to properly bring that foot into alignment. Parents need to be taught the importance about cast care, checking for circulation problems as well in the affected extremity. Our next pediatric musculoskeletal condition we're going to look at are the couple of different types of childhood bone cancers. We have 2 types of childhood bone cancers that I want to mention. One is osteosarcoma and the other is Ewing sarcoma. These types of cancers tend to have an onset around 10 to 15 years of age, up to about 20 years of age, with the peak being around age 15. Bone cancers are more common in boys than they are in girls with both types. Both types do tend to primarily occur in the long bones of the body, with the femur being the #1 site of occurrence in both osteosarcoma and Ewing sarcoma. It can also be found in the tibia and the humerus for each one. And with Ewing sarcoma, we also tend to see it occur in the pelvis and the ribs. And oftentimes Ewing sarcoma will involve the surrounding soft tissue as well as the bone. Some of the most common symptoms of childhood bone cancer early on is just mistaken for what parents may refer to as growing pains, because the most common symptoms with both types are often a dull ache that occurs, a dull aching type of pain that occurs for months prior to the diagnosis, and swelling at the site in both types. Another problem that can be associated with these types of bone cancers is pathological fractures. And frequently, the pathological fracture or another type of trauma can be the reason that the bone cancer is actually originally found. A few notable differences with osteosarcoma: this tends to arise from the osseous tissue of the bone and needs to be treated with a radical resection or amputation in addition to radiation and chemotherapy. Ewing sarcoma, on the other hand, tends to be growths that occur in the marrow of the long bones, and as I mentioned earlier, in the surrounding soft tissue. Ewing sarcoma is more likely to develop malignancy and spread to other parts of the body than osteosarcoma. However, Ewing sarcoma tumors do tend to be more sensitive to radiation and chemo, so amputation is less likely with Ewing sarcoma than it is with the osteosarcoma. Used to the treatment protocol for osteosarcoma was almost always amputation, either a partial or complete amputation of the affected extremity. Surgical approaches and cancer treatments have made a lot of progress over the years, and they have approaches that are able to preserve the majority of the limb, and they call these limb-saving surgeries that can be done more frequently than in the past for osteosarcoma. Muscular dystrophy is a group of X-linked recessive disorders that are characterized by progressive symmetric wasting of a particular group of skeletal muscles. There are several different types of muscular dystrophy. I only have two pointed out here on the slide. These are the two most common types. First, Duchenne's muscular dystrophy, which usually has an onset before age 5, and Becker's muscular dystrophy, which has an onset between the ages of 5 and 15. The type of muscular dystrophy that the child is diagnosed with depends on the particular group of skeletal muscles that are affected with the disease process. However, even though there can be a differing group of skeletal muscles affected, there are some commonalities across the different types of muscular dystrophy. One of the things is that in all types, at some point, you begin to see, some of the first symptoms are that you begin to see an insidious loss of strength in the individual. Oftentimes, muscular dystrophy, as it progresses on, does eventually later in life lead to some type of respiratory failure in most individuals as well. Another commonality between the muscular dystrophies is that although we can see them in men or women, or boys or girls, we do see that happen more often, occur more often in boys than it does in girls. Some clinical manifestations with muscular dystrophy consist of a history of delayed motor development during infancy. It's not uncommon for children diagnosed with muscular dystrophy to have initially been performing their developmental skills at a normal pace, and then they begin to demonstrate some delayed musculoskeletal development as they got a little older. Another common manifestation that we see is what we call calf muscle pseudohypertrophy. This is when the calf muscles become enlarged, but they are not stronger. Gower's sign is a sign that is used to describe when a patient has to use their hands and arms to physically walk up their own body from a squatting position due to a lack of hip and thigh muscle strength. And there is an image of this in your textbook that you can see what Gower's sign is referring to, how that looks. Diagnosis of muscular dystrophy is done a couple of ways. One, through a muscle biopsy, which would reveal degeneration of the muscle fibers, and two, the myelogram, which would be the electrical stimulation of the muscles and the recording of contractions that show a decrease in strength. In addition to that, blood testing can be done to detect gene mutations that determine whether or not a parent is actually a carrier of the genes that cause muscular dystrophy. There is no single treatment for muscular dystrophy, and there is no cure. So treatment is primarily going to be supportive and symptomatic. Our goals of treatment in the child with muscular dystrophy is going to be to preserve their mobility and independence for as long as possible. We're going to do that through resources like physical therapy and the use of several different types of orthopedic appliances. The last condition we're going to look at is juvenile idiopathic arthritis. Overall, juvenile arthritis is a group of pediatric diseases that isn't really one specific disease. Juvenile arthritis, speaking of that first, is an umbrella term that refers to a group of chronic autoimmune inflammatory diseases that are known to develop in children under the age of 16. As far as that group of chronic autoimmune diseases go, we're going to focus on one. This one, and again, these are autoimmune diseases specific to children. So we have a separate lecture that covers some of the musculoskeletal autoimmune disorders, but we don't talk about juvenile arthritis over there. I put it over here because I want you to understand that this is specific to kids, and it is diagnosed in kids who are under the age of 16. So as I mentioned, juvenile arthritis is the umbrella term for the group of chronic autoimmune diseases in kids. Juvenile idiopathic arthritis is one of the most common forms of juvenile arthritis. And to break that down even further, juvenile idiopathic arthritis has 6 different types. I don't go over the 6 different types with you or make you specifically know them, but it is important to understand that the 6 different types of juvenile idiopathic arthritis range anywhere from very mild to very severe forms. The peak onset for diagnosis of juvenile idiopathic arthritis is at first between the ages of 1 and 3, and again between the ages of 8 and 12. Girls are more often diagnosed than boys. And the symptoms of juvenile arthritis can vary. Some of the things that we see that are significant in the diagnostic process are going to be the joint stiffness that the child would report, especially in the morning. They're going to report consistently pain, swelling, and tenderness in some joints. They may have a limp. This can make it appear that the child is not able to perform motor skills that he or she had recently learned, especially in younger children. Persistent fevers, a rash is also common, and some vision issues such as eye redness or eye pain and blurred vision. Those are all some symptoms that we would watch for and note with juvenile idiopathic arthritis. One factor that can determine how severe juvenile idiopathic arthritis is in the number of joints that are affected. The more joints that are affected, the worse the case of juvenile idiopathic arthritis is going to be. Diagnosis is made by exclusion, which means we're going to rule out any other possible cause for the joint pain and the vision problems that are likely going to be present in this child before we rule in that juvenile idiopathic arthritis is the diagnosis. There are several different labs that are going to be done that can help to support the diagnosis. And another criteria for diagnosis is going to be that this child is under the age of 16 and that they are having inflammation that is lasting more than 6 weeks in at least one joint. Uveitis is something else that we do need to be concerned about in children with this particular condition. Uveitis is the inflammation of the anterior chamber of the eye. Children with juvenile idiopathic arthritis need to have very frequent eye exams done to monitor for this inflammation occurring, because if it is not caught early and if the child's not old enough to accurately report vision problems, it can cause blindness if it's not caught promptly. There is no cure for juvenile idiopathic arthritis. Our goal of therapy is to preserve the function in the joint or joints that are affected, to minimize the effects of the inflammation, to control the child's pain, and to try and promote normal growth and development. Ultimately, our goal really is going to be to put the child into remission. Remission is longer and more likely when 4 or less joints are affected. Over half of all kids diagnosed with this go into remission before they reach adulthood. As far as drug therapy for the treatment of juvenile idiopathic arthritis, NSAIDs is the first line of treatment in kids. Second, we can add in some what we call DMARDs, which are disease-modifying anti-rheumatic drugs. One of the most commonly used DMARDs is methotrexate, and this is the second line of treatment in kids who fail to respond well with just the NSAID therapy. It's important to note with methotrexate that you need to be monitoring CBCs and LFTs, as methotrexate can affect the complete blood count. It can cause problems like agranulocytosis, and it can affect liver function as well. So we want to watch that closely. Some other DMARDs that might be used in the treatment of juvenile idiopathic arthritis may include hydroxychloroquine, otherwise known as Plaquenil, and sulfasalazine. which is also brand name known as azolfidine. Corticosteroids, if used, should only be used short-term during bouts of incapacitating arthritis or during a period of the uveitis, that inflammation in the eye. Corticosteroids can be administered orally. They may be administered IV as eye drops or even intra-articular, depending on where the inflammation is at. The last group of drug therapy mentioned there is the biologic agents. Biologics are also possibly going to be used in this kid, especially kids who aren't responding well to our first options. And these are drugs that block what is known as the tumor necrosis factor, or TNF. So these are also referred to as anti-TNF drugs. Some of the most common biologics that might be used are Interacept, which can be given subcutaneously, and Abatacept, which is given intravenously. Therapy is also an important part of the treatment regimen for kids with this condition, and some of the best therapy that is recommended for juvenile idiopathic arthritis is swimming. So the kid can get adequate amounts of exercise through swimming with a very low impact on their joints. Splinting is also frequently used as a therapy measure, and the splinting can be used periodically at the child's comfort level. They're given a splint on whatever joints are affected, or a splint or a brace that they can apply and take off as they need. We talk about Lyme's disease with the pediatric musculoskeletal conditions primarily because one of the most prominent symptoms after the bullseye rash is the joint pain, or the arthritic type pain that most children exhibit in association with a Lyme's disease diagnosis. Lyme's disease is caused and transmitted by the bite of a tick. Some symptoms do include the erythema migrans, or the bullseye rash, and the joint pain, and some other miscellaneous flu-like symptoms. Earliest symptoms with Lyme's disease occur within the first 30 days, and at first it comes in 3 stages, and the first stage is referred to as the early localized disease. This is when the bullseye rash begins, followed by fatigue and a headache, and then followed by the joint pain and some neck pain, and then possibly a fever. So the flu-like symptoms start to appear. The localized disease then progresses to what is known as the second stage, or the early disseminated disease. This stage can start anywhere from about 2 weeks after the bite, and it can last until the chronic symptoms develop. The early disseminated disease is an indication that it's beginning to spread to other parts of the body. The rash expands, and that's where it becomes, rather than just the very small, tiny rash, it'll spread and be known as that bullseye rash, the more large rash, what we refer to as the erythema migrans. Their fatigue and their arthralgia, which is another term for their joint pain, and their fever become more common. During this second stage, their neural symptoms often appear, and one frequent neural symptom that shows up with Lyme's disease is what's known as almost like a Bell's palsy. It's a facial nerve palsy that appears. They can begin to exhibit chronic pain also from the nerves being affected, carditis in the heart, and the headache can become more severe as a result of the brain being affected. Late disease is the third stage, and this can last for months to years when their arthritis is persistent, migrating from one joint to the next, and most often affecting the larger joints like the knees. As far as diagnosis goes, lab testing is done to confirm the presence of Lyme disease, but it can take several weeks for results, so oftentimes patients are treated symptomatically while they are waiting on results to return, which can delay antibiotic administration and actually cause additional issues with symptomatic occurrence. Treatment that is done with antibiotics, and it's done for a minimum of 2 weeks up to several months. It can be PO or IV depending on when the Lyme's disease occurred and the prevalence of the patient's symptoms. And it's also important to note that many patients continue to have symptoms even after treatment, and it's not uncommon for patients to relapse with Lyme's disease and need retreatment.